Thank you very much for having me this afternoon. I'm here to present our abstract entitled Improved Outcomes at Reduced Healthcare Costs After Implementation of a Hernia-Specific Enhanced Recovery or ERAS Pathway. We have no disclosures. So to start, ventral hernia is a common surgical diagnosis, as you all know. There are approximately 350,000 of them performed in the United States annually. Of note, there are about 4 million laparotomies that are performed in the US with an incisional hernia rate of between 3 and 29%. So the total yearly cost of repairing the hernias that we have in the United States is about $3 billion as of 2006. With the increasing volume of abdominal surgery, the increase of ventral hernia can only be expected to grow with the associated costs. It's important that surgeons and providers are aware of these costs and try to improve their efficiency without compromising patient safety. So this brings us to the idea of ERAS. The ERAS protocol is a comprehensive perioperative plan intended primarily for elective surgery. Its main goals are to improve the surgical patient's recovery and reduce perioperative risk. Colorectal surgery groups have implemented ERAS with remarkable results. ERAS consists of 3 important phases: pre-op, peri-op, and post-op. This graphic highlights our specific ERAS pathway at the University of Washington. The preoperative phase consists of smoking cessation for about 8 weeks, counseling about the surgery and about the ERAS protocol, glucose control with a hemoglobin A1C of less than 8, immunonutrition with arginine supplemented diets to promote wound healing, and an internal medicine consult clinic for preoperative optimization of other comorbidities. The intraoperative phase consists of advanced pain management with epidural analgesia or TAP blocks, intraoperative glucose control, and limited fluid administration of less than 2.5 liters of crystalloid. The postoperative management consists of early postoperative feeding with a clear diet, limited use of opioid narcotics, and aggressive mobilization and physical activity. This is an example of the handout that we give to patients about our specific care map, just so they can have a bit more information as to what they can expect during their stay with us. And these subsequent slides demonstrate in more detail our pathway from preoperative to days 1 through about 4, as we expect. If you're interested, you can go to the SAGES website and get more information. So there's limited data about the role of ERAS in hernia surgery. To date, there are about 3 studies that look at the role of ERAS, and they've demonstrated a quicker return to bowel function, reduction in surgical site infection, and a decrease in hospital length of stay. There is no current published data on the impact of ERAS and the cost of hernia surgery. Our group hypothesizes that ERAS and ventral hernia will lead to improved patient outcomes and reduced cost. So we performed a retrospective analysis on prospective data collected from our quality improvement database. And this data was culled from patients who were undergoing open and laparoscopic ventral hernia repairs. We chose 2 sites within the University of Washington system, University of Washington Medical Center and Northwestern Hospital. We looked at these sites because they have a large volume of hernia cases, and we thought there would be benefit to standardizing across both systems. We collected data about 1 year before the implementation of the ERAS protocol and 18 months afterward. We included all adult patients undergoing an inpatient ventral hernia repair, and we excluded emergent and outpatient and emergent cases, pardon me. Our outcomes of interest were as follows: mortality, length of stay, ICU length of stay, hospital costs, and readmission rates. We looked at mean values and compared prior and after the implementation of ERAS. As our data came from a QI database, we did not have access to demographic variables, so we could not present those to you. This particular slide shows the volume of ventral hernia cases before and after the implementation of ERAS. As you can see, there are a total of 402 cases during our study period, 138 before ERAS and 264 afterward. And you can see the breakdown between open and laparoscopic. It's important to note that the open cases are a bit higher volume just because the laparoscopic cases were typically outpatient cases and were discharged right from the PACU. So this slide demonstrates the length of hospital stay pre and post initiation of our protocol. As you can see readily, there's a significant decline in the length of stay across all cases. It's most notable for laparoscopic ventral hernia repair after ERAS. This slide demonstrates the decline in ICU length of stay after ERAS. It's most appreciable for open ventral hernia as opposed to the laparoscopic cases. And this slide demonstrates, let's see, there we go. This just demonstrates our 30-day readmission after ERAS. You can see most of the contribution to 30-day readmission was from the laparoscopic cases, which went from approximately 9% to 0%. Open cases didn't really have an appreciable change in terms of 30-day readmission. These two subsequent slides are kind of the ones that I want to highlight the most. We noticed a significant drop in our healthcare costs associated with both open and laparoscopic cases. You can see there's a decline about $1,958 between pre-ERAS and post-ERAS. And when they're broken down by open versus laparoscopic, there's approximately the same amount of change, decrement in case price. So over the study period, we actually saved about $500,000, or $516,000 to be exact, with the ERAS protocol between both hospitals. So to summarize, implementation of ERAS pathway at our system resulted in a reduced length of stay, both total days and ICU days, reduced rate of 30-day readmission, more apparent in the laparoscopic group, reduced direct hospital costs, approximately $1,958, and a total savings of more than $500,000. So just to conclude, this is a retrospective analysis that demonstrates, again, significant improvement in our cohort for ventral hernia repair after implementation of our ERAS protocol. There were expected improvements in regards to the length of stay and lower rates of readmission, but our most important finding is just the cost that we saved along the way. Again, $2,000 per case approximately. We do have many areas for improvement in this study. Again, it's a quality improvement database, and our specific database does not have access to demographic variables. It's something that we're working on and hope to have access to in the future so that we can kind of be more, get more information as to our patient characteristics and who benefits most from ERAS. We also didn't have a way to assess for compliance as well to see which providers were actually fulfilling the ERAS protocol. Again, this study had about 20 different surgeons who were involved, and we didn't really have a good way to verify what components were being used at any phase. But we anticipate with improved compliance, we could actually achieve greater cost savings without harm to the patients. Thank you very much.